Welcome, everyone. I'm Dick Deming. I'm Medical Director of MercyOne Cancer Center and the founder of Above and Beyond Cancer. Welcome to our weekly cancer education series. It's brought to you in part by a grant from the Rosalie and Sherry Exline Ziegler Fund. And tonight, I get to introduce to you my friend and colleague, Dr. Karen Kemp-Glock. Welcome, Karen.
Thank you.
So Dr. Kemp is a OBGYN physician and a specialist in menopausal health. So we're going to talk a bit today about menopause in general, both natural menopause, and then some of the menopause that gets sprung on women as they undergo cancer treatment, and just how we can manage that and help promote better health.
Great.
So welcome.
Thank you for having me.
You're from Iowa, from
Yes.
Ames, Iowa.
Yep.
So grew up there. And what was your claim to fame in high school?
Oh, I don't know that I had a claim to fame.
And then, like many people who live in a college town, you decided you needed a different experience than the Iowa State experience.
I did.
So you went to Texas for undergrad.
I did. I went to Texas Lutheran College in Seguin, Texas, which is down by San Antonio.
And how did you happen to choose that university?
My dad taught there. That was his first teaching position prior to Iowa State. And I thought I needed to experience something besides Iowa. And
what did your dad teach?
Veterinary pathology.
Okay.
Yep.
So was he a veterinarian?
He wasn't. He was a parasitologist.
Gotcha.
Had his PhD in parasitology and worked in the pathology department and taught the vet students there.
So when you went to college, what was your first declared major?
Economics.
Okay. So it wasn't like you went there to become a parasitologist or a physician.
No.
And then when along your path did you decide that you wanted to go into healthcare?
Well, my mom's a nurse and my dad worked in veterinary medicine. So medicine was always kind of in the background. And then I strayed my first year in college and then came back to it after the first semester of economics and decided that science was more my interest.
And then after your undergrad degree, then you got a master's. You came back to Iowa, but went to the University of Iowa as opposed to Iowa State.
Right.
Okay. And what was that master's in?
That was in chemistry.
Okay.
And then I worked at the diagnostic lab at Iowa State for a few years and decided my true calling was medicine. So decided to go back into medicine at medical school in Des Moines.
So at Des Moines University, and those of us who go through medicine, some people sort of know what they want to do. And many of us, I just remember distinctly every one of my clinical rotations I really liked. And it was like I wanted to be whatever I was doing at that particular time. At what point did you decide to go into OBGYN?
That's what I always wanted to do.
Really?
Yep. I really love the preventative aspect of the healthcare and women's healthcare and delivering babies and doing surgery. So, and taking care of women from start to finish.
When you were in medical school, about what proportion of your class were female?
Probably 50%.
Okay.
Yeah.
Sorry. Yeah.
Yeah.
So back in the olden days, we had maybe 10%.
Yeah.
And so maybe explain a little bit about the career path, the education path, how many years of training to become an OBGYN, and then also some of the more specialized training that you've done even after being a board certified OBGYN.
Sure. So 4 years of college, obviously, and then 4 years in medical school. And then an OBGYN residency is an additional 4 years. So 12 years of training to hit the door as a practicing OBGYN. So in residency, the first 2 years are mainly obstetrically driven, and the last 2 years are more surgically driven for the gynecology and the surgical aspect. And then additional training that I did for menopausal medicine was become certified as a menopause practitioner through the North American Menopause Society. And that consists of studying and taking a test to show a competency in menopausal medicine. And then I've also done additional training in sexual medicine as well through the International Society for the Study of Women's Sexual Health. So,
okay. Maybe give a little bit of a primer for the audience about menopause, and let's just say natural, what the natural process is one goes through life without a cancer or any other illness.
Sure. Well, the average age of menopause in our country is about 51 years of age. And so the definition of menopause is no period for 12 months, unless you're on some kind of medication or had surgery to cause that. So we know you're menopausal when you've stopped having a period for a full 12 months. The transition into menopause is a continuum that may be several years to up to 7 to 8 years, where women experience symptoms of menopause, such as hot flashes and night sweats and mood disorders and joint aches and pains. They may have some irregular menstrual cycles before they completely get into menopause. And also then sexual dysfunction and vaginal dryness that can contribute to pain and problems there.
And in the natural process, do the ovaries slowly start making less estrogen? Is that a slow, gradual process? And does that happen over, you mentioned maybe 7 to 8 years? Or does it in some women happen abruptly?
It's a gradual process, but it's different for every woman. We do know that reproductive capacity decreases starting in the early to mid 30s. And so the ovary's not functioning as well and producing as many eggs. Women have a finite number of eggs that they produce over their lifetime. As far as that transition into menopause, it really varies woman to woman. Someone may have regular periods, stop having them, never have another one, not have a lot of symptoms, and just kind of sail through. They're the lucky ones. Other women may deal with a lot of disruption to their menstrual cycle, a lot of symptoms of hormone levels being way up and down, causing mood swings and uncomfortable feelings, hot flushes and night sweats and the such. So it's variable from woman to woman, from easy to pretty difficult.
And what percent of women do you think seek medical attention because of menopausal symptoms?
Not a lot.
Not a lot.
Yeah,
Most women just sort of, well, it's sort of my lot in life, a stiff upper lip, and just deal with it.
Yep. And we talk about puberty a lot and what to expect when girls enter puberty and what happens in the reproductive years, but we sort of don't talk about menopause at all. And a lot of women, their mothers don't talk about it. Their families don't talk about it. They don't understand what's happening to their bodies. And it's just kind of swept under the rug. There's not a lot of training in medical school or residency about menopause. So it doesn't get a lot of focus. And I think now, especially as our population is aging and we're having more women enter menopause, there's more of a push and more public awareness that it can be a very difficult time for women, but there are ways to make it more comfortable, and life doesn't end at menopause.
Yeah. And you talked a little, you defined it by, the menstrual period, that is the definition. And I think people know that, and people know about the hot flashes, but you touched on and maybe expand a little bit, talk a little bit more about some of the other physical symptoms that aren't always just below the belt, and maybe some of the psychological, emotional, and other symptoms that some women might experience as part of the whole symptomatology of menopause.
Sure. We know that menopause and the transition into menopause, which is termed perimenopause, is a window of vulnerability for all women to develop anxiety and depression above baseline. If someone has been treated for anxiety and depression earlier in life, such as postpartum depression or another episode, they're at even higher risk for that to occur during the transition into menopause. So a lot of women experience a lot of anxiety. They can't put their finger on it. They don't feel right. They may have depressive symptoms. It's a time in women's life when there's a lot of changes going on. They may be at the peak of their career. They may have younger children if they started childbearing later in life, and be dealing with aging parents and kind of get put into that sandwich generation. Oftentimes, they may have older children that are either leaving the nest, or maybe they've left and they're coming back, depending on what's going on. Relationships change. So there's a lot going on at that point in women's life. And then you throw in their hormonal ups and downs and the transition into menopause, and And it's a very vulnerable time for women to develop anxiety and depression and moodiness. And a lot of times they don't understand what's going on, and their family doesn't understand what's going on.
And there's a change in metabolism that happens in the body as well.
Absolutely. So menopause occurs at midlife, and metabolism changes at midlife. So we start to lose lean muscle mass, which is where metabolism takes place. So a lot of women experience unwanted weight gain, and that weight gain tends to go to the middle because our estrogen receptors in our hips and thighs are not as active. So the fat deposits in the midsection. And so I hear it every day in my practice. I have done nothing differently, and I keep gaining weight. And that's because our bodies require less calories, but we're not doing anything differently. So we have to make adjustments to our eating habits and making sure we get plenty of sources of good lean protein and fresh fruits and vegetables, and watch some of the carbohydrates, simple carbohydrates.
And there can be
sugars.
also an effect on hair, an effect on their skeleton.
Yep. Women oftentimes will start to notice hair loss, whether it's global, meaning all over your hair just is thinning, or sometimes more what we call male pattern hair loss, where they start to thin around the temples or maybe over the crown of the head.
Are you looking at me?
No, I'm looking at you.
I do resemble some of those, yeah.
And then as far as bone health, women lay down their maximum density of bone in their late teens, early 20s. And after that, it's pretty stable. But we know that as women transition through menopause, they'll lose up to 10 to 12% of their bone mass or bone density, which puts them at increased risk to develop thin bones and eventually osteoporosis. And then as you progress through menopause, you start to lose about 1% every year. So bone health is very important. So maintaining weight-bearing exercise, making sure you're getting plenty of calcium and vitamin D in your diet, or supplementing if you're not getting it in your diet, and being aware of that. Estrogen is protective for our bones, and as we start to lose our estrogen, we lose that bone protection.
So, doctor, why don't we just give everyone estrogens, starting at age 40, 45, and just let them be on estrogen for the rest of their life?
Because estrogens do carry some risks associated as well. So,
yeah.
Yes.
So what are the risks associated with treating every menopausal woman with estrogen?
Well, not every menopausal woman is a candidate for estrogen, depending on their own health history. Obviously, if they have an estrogen-dependent cancer, that would be someone that's not eligible for estrogen therapy, because we don't want to potentially feed that cancer. Women that have blood clotting disorders, where they may be at a higher risk to develop blood clots in their legs that can break off and go to their lungs, are not good candidates for systemic estrogen therapy. Women that have significant cardiac disease or significant risk for stroke aren't good candidates for estrogen. So we have to be a little bit careful about who is a good candidate and who is not. Short-term use of estrogen doesn't increase risk for breast cancer. Longer-term use can slightly increase that risk.
And what's the dividing between short-term and long-term?
When we start to get out to about 5 to 7 years of estrogen therapy,
okay.
That's where we start to see a slight increased risk.
Gotcha.
It's about 6 out of 10,000 women.
But it'd be 3 years, 4 years would be considered short-term use of estrogens?
Right. Now, we will see that with estrogen use, the breast tissue can appear more dense on mammogram, and that can reduce the sensitivity. So we have to be cognizant of that.
Mm-hmm. So if a woman who doesn't have cancer or any known disease process stops having menstrual periods, any reason to do blood tests? Any reason to do bone density? Any reason to do anything special as a woman enters menopause?
Well, as far as like hormonal testing goes, we don't do a lot of it because there aren't set standards of where the hormone levels should be in any given woman at any given time of day, any given time in her cycle. So the basic premises is to treat for symptom relief with the lowest dose for the least amount of time. So we usually start low and titrate up. Typically, when we start hormone replacement therapy for someone in menopause, we're treating symptoms such as vasomotor symptoms, the hot flashes and the night sweats, and then we get those benefits of the other protective effects along with that. It's not necessarily approved to like treat for decrease in cardiovascular disease or treat for prevention of osteoporosis if we're not treating for other symptoms. There are other medications for that.
And several times we've mentioned estrogen.
Mhm.
There's also progesterone. And maybe give us a little primer on the difference between estrogen and progesterone. Do they both diminish after menopause? Is there a difference between treating a woman with just estrogen versus a combination of estrogen and progesterone?
Yeah, that's a great question. So estrogen is produced by the ovary mainly. There is some peripheral conversion of the testosterone that we produce. Women do have testosterone into estrogen as well. Progesterone is mainly produced by the cyst that is developed from where the egg is released on the ovary. And the purpose of the progesterone is to sustain a pregnancy. So once we stop ovulating, our progesterone levels go way down because we're not producing that cyst anymore. When we treat for perimenopausal and menopausal women with hormone therapy, basically, if we use progesterone, is mainly driven by if she still has her uterus or not. So if a woman has not had a hysterectomy and she still has her uterus, we add progesterone to protect the lining of the uterus, because if we treat with just estrogen, we can potentially cause that lining of the uterus to overgrow and become abnormal, and we don't want to do that. So the progesterone helps to keep that in check.
Okay. And the effect of female hormones on bone strengthening, is that purely a estrogen effect, or does progesterone play any role in skeletal strength?
Sure, it's mainly estrogen
Okay.
that is the driving force behind bone strength.
Okay.
Yeah.
Let's switch gears just a little bit and talk about the impact that cancer in women has on menopause and sexual health. So I'm kind of thinking of two broad categories. One, the most common cancer in women, and that's breast cancer, and the role that breast cancer treatment has on menopause and on sexual function. And then the other would be cancer of, let's say, the cervix or the uterus, where obviously or the ovaries, where removal of those organs might be part of the treatment. What's the role that breast cancer treatment plays in maybe causing menopause to happen at an earlier age? So let's say a woman is 42 years old, still having regular menstrual periods, and is diagnosed with breast cancer. How could the breast cancer treatment potentially throw a woman into early menopause?
Sure. So you're more well-versed in this than I am, but the chemotherapy that we treat women with breast cancer can often cause the ovaries to stop functioning. It may be temporary. When that treatment is finished, they may resume functioning. But then the adjuvant treatment that's done after that initial chemotherapy may cause her to become menopausal or have menopausal type side effects. Such as tamoxifen. And then if you're talking about postmenopausal treatment, the aromatase inhibitors that we use in postmenopausal women drive the estrogen levels to essentially zero. So their symptoms can be greatly exacerbated by that.
Yeah. So what you and I see often is a woman who is premenopausal, has a screening mammogram, small cancer in the breast, no symptoms, and then they get put on this sort of conveyor belt of cancer treatment that might include chemotherapy that stops their ovaries from making estrogen, surgery, radiation, and then anti-estrogens after that. And the studies show that for premenopausal women who've been diagnosed with breast cancer, 80% of them will gain 20 pounds during the course of treatment. And normally people think of, patients going through cancer are going to lose weight. And unfortunately, I mean, adding injury to insult with women that are premenopausal, they go through the cancer treatment, they come out the other end with really their health isn't as good. They've been thrown into menopause, they've gained weight, their metabolism has slowed down, they've had the emotional changes. And the consolation prize is, we've cured you of your cancer, but the lifelong consequences can be severe, especially if we don't refer them for some specialized help.
Right. Absolutely.
Maybe talk a little bit about, let's say I have sent you a patient because I've just seen her for her survivorship visit. She's cancer-free, but over the last year, she's gone from premenopausal, fit and active and in shape, to now postmenopausal, still exercising as much as ever, but having changes in her body shape, gaining weight, thinning hair, and just feeling emotionally exhausted. What's the process of the evaluation that you would do for this type of patient?
Well, first of all, we'd sit down and go through a complete history of, what her cycles were like before, what she was feeling before, what her therapy consisted of, and any medications that she's currently on, any side effects from those medications, any intervening health problems that may have developed in other body systems as a result of her therapy. And then we look at both her physical complaints and her psychosocial complaints. So, part of her therapy may be counseling with a counselor to help kind of put all this together and deal with the emotions that are all over the place on having cancer, dealing with the after effects of cancer, dealing with changing body image. A lot of times there's stress in personal relationships because of the way the cancer's affected her relationship with her significant other or her family members. So that's an important part. And then we look at her physical symptoms. Is she having significant hot flashes and night sweats that are interfering with daily activities of living or with her job or with her sleep? And then we address how we might be able to alleviate some of those symptoms safely. We talk about diet and exercise. Disruption in sleep can cause a significant weight gain. We know that whether you've had cancer or not had cancer, just of the way it resets the hormonal signals in the body and the cortisol levels. So that's an important component too. And then we talk about other issues she might be having as far as if she's having vaginal dryness, pain with sexual activity, and what we can do to alleviate those symptoms to help, intimacy be better in her life, which can have a great impact on relationship and how she feels about herself and so on.
So we talked about a woman going through natural menopause who doesn't have a history of cancer, that estrogen might be the go-to drug to help with those symptoms, but that a woman who has estrogen receptor breast cancer who gets suddenly thrown into menopause, you're going to be very reluctant to treat that woman with estrogen.
Right. She's really not a candidate for systemic estrogen. So there are other medications we can use systemically to treat the hot flashes and the night sweats. And the FDA-approved medication would be paroxetine, but we do have to be careful if she's on tamoxifen because the paroxetine interferes with the metabolism of tamoxifen. So if she's on tamoxifen, that's kind of off the board. There are some other medications in that same class called SSRIs, or selective serotonin reuptake inhibitors, such as escitalopram or citalopram. Venlafaxine is a similar medication, and those are medications we can use that can be effective in controlling the hot flashes that are non-hormonal and are safe for her to use. We also can use a medication that traditionally has been prescribed for overactive bladder, called oxybutynin, and that tends to be very effective. We do have to be a little careful with that medication, though, because in older women or long-term use, there may be a slight increased risk for dementia, so we need to be cognizant of that and be careful of that. So those are considered off-label uses, but there's quite a bit of clinical data to support them. There's also another brand new medication that was just FDA approved May 12th to treat hot flashes. It's non-hormonal, and that's called fezolinetant, and it acts on what we call the candy neurons in the brain that regulate the thermoregulatory system in the body. And so that's a neurokinin 3 receptor antagonist. So it works directly in the brain to block the neurons that tell your body to heat up.
Mm.
And those neurons become overactive when estrogen is withdrawn. So that's new and exciting. I haven't had a chance to prescribe it yet because it hasn't even been 2 weeks.
Wow.
But that's something that is a new tool in our kit that hopefully we will be able to use.
Just out of curiosity, is that drug approved for any other indications and other temperature regulations? I don't know, people with super high fevers or
I believe just hot flat vasomotor symptoms
okay.
in menopausal women, whether or not they've had breast cancer.
Okay.
Yes.
And what about the role of vaginal creams that contain estrogen to help with lubrication, to help with keeping the tissues responding to the estrogen? Are those safe to use in women that have had breast cancer?
Yes and no.
Okay.
So first of all, when we're talking about vaginal dryness and decrease in lubrication of the tissues, the vagina and the muscles in the vagina and the bladder and the urethra all have estrogen receptors. So even for a woman that doesn't have breast cancer, that's menopausal or in an estrogen deficient state, we can see some changes in those tissues that can affect how they function. We can see an increase in pain with intercourse, perhaps bleeding because the tissues are so thin and friable, decreased lubrication, decreased arousal and ability to climax, and then increased urinary frequency. And some women have problems with recurrent urinary tract infections. So vaginal estrogen is considered local hormone therapy, and the estrogen isn't absorbed into the body like it is if we take it by pill or use it on our skin, which is called transdermal. So theoretically, it should be safe. However, it depends on the patient. It depends on what type of breast cancer she has. It depends on what her adjuvant therapies are. And if we prescribe it, we do it in consultation with her oncologist.
Right.
So when women use vaginal estrogen, initially there may be a very slight increase in the estrogen levels in the body, but they're still in a postmenopausal range. So perhaps for someone that's more distant from their cancer, they may be on tamoxifen or not on tamoxifen, no metastasis, no or low risk of reoccurrence. That might be a woman that's a candidate to use vaginal estrogen with the approval of our oncologist.
Mm-hmm.
For the women that are on the aromatase inhibitors, the role of those medications are to drive the estrogen levels essentially to zero. So we don't even want to see that slight uptick that we may see transiently with vaginal estrogen. So they tend to be off the board. It tends to be off the board in those patients.
Okay. Let's talk a little bit now about the role of menopause, but also sexual health in women that have had pelvic cancer. So that could be either ovarian or cervix or uterine, vaginal, or even anal cancer with chemotherapy and pelvic radiation, and the impact that those treatments have on both hormonal functioning and in particular sexual functioning.
Right. So with especially with uterine cancer, cervical cancer, vaginal cancer, perhaps anal cancer, radiation tends to be one of the mainstays of treatment. And so that radiation often causes strictures and shortening of the vagina, strictures where it may be scarred and can make sexual activity very painful. Again, when we're talking about an estrogen-dependent cancer, which those all are, with maybe the exception of a vaginal cancer, which may or may not be, we really want to stay away from estrogen. So it'd be pretty hard-pressed to use a vaginal estrogen in those circumstances. We can use vaginal moisturizers and lubricants. Another great therapy is pelvic floor physical therapy, where the patient works with a physical therapist that's been trained in the pelvic floor to help get those muscles to relax, and may include use of like vaginal dilators to open the vagina up more and increase pliability of the vagina, in conjunction with perhaps like trigger point injections to help with a pain, or perhaps using like a topical lidocaine to blunt some of that pain response, and a silicone-based lubricant to make activity more comfortable.
Yeah. And we've talked before, we've had pelvic floor physical therapists as guests, and we've also talked about the role of radiation, and the thing that some people don't know is that the fibrosing effect as the tissue scars and becomes stiffer, that happens over time. It doesn't happen right away, and it gets worse over years. And so getting a physical therapist and paying attention to that, the use of dilators, is really important over several years, because it's not just a side effect that happens while you're going through the treatment.
Correct.
Yeah. What about the role of hysterectomy or other pelvic surgery? Let's leave radiation out of this. In terms of as women get older, both urinary function and sexual function. What are some of the issues that women experience in terms of pelvic dysfunction, urination, bowel movements, and sexual as women age?
I'm sorry, with or without hysterectomy?
You know what? I asked it both ways. So yeah, you get to answer it both ways. Okay. Maybe naturally first, in terms of women who haven't had a hysterectomy, but through the menopause and aging, what are some of the issues that postmenopausal women face?
Sure. So, as I said, there's estrogen receptors in those structures. So as women age and the estrogen becomes deficient, the tissue's thin, you don't produce as much vaginal lubrication, the muscles don't contract. Orgasm comes from the vascular musculature, so they may be blunted or less. It takes women more difficult, or it may be more difficult for them to become aroused and reach climax, which can, it blunts their sexual response, and then it becomes less pleasurable. And that can have an impact on libido, which is the desire to have sex. So it's all interwoven. As far as effect on urination and bowel movements, women can develop, whether or not it's not necessarily due to age, but they can develop laxity in the vagina called a cystocele or a rectocele, which is kind of like a hernia in the vagina. And that can impact sexual function, impact their ability to hold their urine, or they may lose urine when they don't want to, which is incontinence, and as well as impact their ability to pass their stool as well. There's also estrogen receptors on the bladder and on the urethra, so they maybe have more problems with urinary urgency, sometimes some incontinence, and recurrent urinary tract infections. So physical therapy during Kegel exercises, maintaining the pliability of those tissues with moisturizers, lubricants, and perhaps estrogen all become important.
And the situation of a woman who's had a hysterectomy, how does that change the anatomy and or function?
Right. So most hysterectomies are done where the cervix is removed as well. And the cervix is the bottom part of the uterus, and that's the part we see in the vagina. And the vagina is attached to the cervix. So when we do a hysterectomy, we have to actually incise that vagina around the cervix to remove the cervix in the uterus. And then we suture the vagina closed. So it changes the architecture a little bit. It can change the angle of the vagina. It can foreshorten the vagina and make it shorter if the surgeon isn't careful. Or in the case of for a cervical cancer, sometimes you want to remove the top part of the vagina as part of making sure you get all of those cells, and that can foreshorten the vagina, make it shorter. And so both of those things can cause a change in intercourse or how the woman perceives it. Most of the time, if it's for a benign condition, I would always tell my patients sex may feel a little bit different, not necessarily better, not necessarily worse, but it'll be your new norm. Just like after you have a baby, sometimes things have changed a little bit, and so there's like a new norm. Most women, the orgasm isn't derived from vaginal penetration, it's derived from clitoral stimulation. So if they were able to climax before their surgery, they should be able to climax afterwards too.
So we're talking sexual health, and I would say that most healthcare providers that aren't gynecologists or urologists don't spend a lot of time talking about sexual health, and sort of, I think the defense is, well, if the patient really wants to talk about it, they'll bring it up. I'm not going to bring it up. And the patient's probably going, well, if it was important, the doctor will bring it up. So they're not bringing it up, I'm not going to bring it up. And the consequence is that most doctor-patients interactions don't mention sexual health at all.
Correct.
Yeah. What is there new training? Is there, how do you become comfortable, both as a physician and then making a patient comfortable about having the conversation?
Right. Well, it's an important conversation to have. And again, a lot of patients won't bring it up because they're embarrassed. But you can ask a simple, open-ended question. Has sex been uncomfortable? Same with like urinary incontinence. You can ask a simple question. Are you losing urine when you don't want to? And that opens up a door and they'll be like, oh, they care. I can start talking about this. Or I'll ask, are you having any dryness? Are you having any discomfort with intercourse? And it opens up the conversation and it gives that permission to the patient to discuss it with you, and gives them the reassurance that this is important and you're willing to talk about it with them.
And when you are engaged with a patient, a female patient, about sexual health, sexual dysfunction, at what point does this become a couples conversation? Assuming the patient is in a monogamous, long-term, loving
Sure.
Relationship.
Well, that kind of depends on the patient. Probably the majority of my patients come in without their partner, but some do bring their partners along. And sometimes it's the partner that's kind of pushed them to come in because it's creating conflict in the relationship. And so an important component of sexual health and sexual function, because it's not just the physical aspect of it, but it's what we call a biopsychosocial model. So everything has to be working, physically things need to be working well, but then psychologically and socially things need to be working well too. So couples therapy is a very important component of having a healthy sexual relationship. So it's always mentioned, it's always talked about, it's always done in conjunction with other modalities of treatment. And whether, and I don't necessarily do the counseling, I will send them to a counselor. But it's an important component. And a lot of times there's just a mismatch between partners, and it takes some communication to kind of bring everybody back to, it's like, oh, you're experiencing that, or you're experiencing that, or I thought this and you thought that, and kind of get everybody on the same wavelength.
And so you're a gynecologist and you also have specialty training in menopause and sexual health. And I know some urologists who also have some additional training that in sexual health. What is a sex therapist? Is that a clinical entity? And how does a sex therapist differ from a physician who is certified in sexual health?
So a sexual therapist tends to deal with counseling regarding sexual function from the psychosocial standpoint. And it just depends on what that therapy may be. It may be individual or couples counseling. A lot of it just encompasses relationship and communication. So it's not necessarily sex driven, but there are some sexual therapists that, depending on the needs of the couple, may do more mindfulness or have them do assignments at home where perhaps they learn to reconnect with each other both emotionally and physically in a stepwise process. So, yeah.
Great. I think we're going to open it up for questions now. We've got a live studio audience, and we also have folks that are watching us live streaming. If you're watching us live streaming and you have a question, please put it in the comments section. And any questions are open.
Well, I have a question, and I did have that when I got diagnosed with cancer. That light bulb went, ooh, I'm going to lose weight. And that's not the case, because I had two types of chemo and steroids, and I'm a type 2 diabetic. So it was a challenge. But I've heard it mentioned that I was going through menopause before even the cancer happened. But my understanding about menopause, yeah, I was already gaining the weight. My metabolism was slow because I was athletic in high school. Until when I got to 25 or 26, I was warned by the doctor, it's going to slow down. And then I go to the other extreme. I didn't realize how extreme from a size 3 to a size, I won't mention the size now. But anyways, is there a type of exercise or diet for the type of hormones? I mean, when you say you gain fat in certain areas, is there any types of diet or exercise that work?
Yeah, there's not specifically a menopausal diet.
Mhm.
A lot of what is advocated in the literature essentially is like a Mediterranean diet. So lean sources of protein, fish, fresh vegetables, fresh fruits, limit the pastas and the breads, healthy oils such as olive oil, avocado oil, nuts, and a lot of it's moderation. So a lot of us, we've kind of supersized our portions. So what we think is a normal portion isn't necessarily a normal portion. So a lot of times if you're eating a pretty well-balanced diet, sometimes it's just a matter of portion size and weighing your portions out or putting more vegetables on your plate than the other things. It doesn't mean you can't have those. You just have to be careful. But yeah, it changes a lot. So, and then for exercise, the exercise is important for cardiovascular health. Most people can't exercise to the point of losing weight. It's more a matter of maintaining weight you've lost through calorie deficit and then cardiovascular health. So there's been some proponent of like what they call high intensity, so short interval high intensity to kind of rev your metabolism up as opposed to more endurance type like marathoning.
Mhm.
So Dr.
Yeah.
Deming can probably speak to that.
Well, it is interesting, and I think it comes in waves, and not every study is like the definitive study.
Right.
But yeah, there was a study that was last year. It was like 30-second burst of exercise to just rev up your heart rate, and that I'm not sure if this is true, but it was something to the claim that doing that is better than slow running 5 miles. That you actually there's something about that intensity that just kicks in a cardiovascular response. So I'm just paraphrasing a study. I don't know that it just seems too good to be true.
Yeah.
That 30 seconds could be as good as an hour,
Yeah.
but there is, we're learning more and more,
Yeah.
and fortunately, we've got exercise scientists that are looking at it
Right.
and looking at the whole role of the way that nutrition and exercise. We've known for a long time that you want aerobic exercise that gets you huffing and puffing and your heart beating, but we also need to have resistance training, not only to make our muscles stronger, but it also helps make our bones stronger.
Right.
And that you really need a balanced exercise program.
Yeah. I think the important thing is just to move. So I tell my patients, make small changes to the diet. I have patients keep a food log everything that crosses your lips, including what you drink, what you eat. Don't cheat. And you can probably find some really easy ways to make some small changes so that over the long term, they're adaptable. And then as far as movement goes, sometimes it's really hard in our busy lives to think, oh, I have to set aside this amount of time to exercise. And then exercise sometimes becomes this negative thing. But just find ways to incorporate more movement. So, take the dog for a walk in the morning, take the stairs instead of the elevator, park a little bit further away. So small things like that. And then I think the studies show that you don't have to have your exercise all in one increment. You can divide it up through the day.
Yeah.
So.
And for people who are fortunate enough to do physical labor during the day, I mean, you don't have to have a gym membership if you're out there chopping down trees and digging holes.
Yeah.
So everything counts as exercise.
Yeah.
It doesn't have to be
Yeah.
going to the gym is exercise.
Right.
Exercise can be raking your lawn, mowing your lawn,
Yeah.
doing gardening. That all counts as exercise.
But it is difficult when you're battling diabetes and you're getting steroids and these treatments. It's kind of a double-edged sword.
Poon,
Yes. Can you talk about someone on tamoxifen having spotting? And what would you recommend? I had a friend that had that, and her doctor recommended a hysterectomy.
so a woman who's been treated for breast cancer and now is on tamoxifen and has some vaginal spotting.
So tamoxifen is what we call a selective estrogen receptor modulator, which means that it works as an anti-estrogen in some tissues, such as the breast, which is why we give it to women with breast cancer at risk for breast cancer. But it acts like an estrogen in other tissues, such as the uterus or the lining of the uterus, the endometrium. So one of the potential side effects of tamoxifen is potential for growth of polyps in that endometrial lining or potentially an endometrial cancer. So if someone is on tamoxifen and they're having spotting, it definitely needs to be evaluated. And depending on what the finding is, a hysterectomy may be indicated. It may be indicated too for peace of mind, so they don't have to worry about that potential side effect because most women are on the tamoxifen fairly long term.
Usually the workup for vaginal spotting in this clinical situation, a woman on tamoxifen, does that start with ultrasound? Does it start with
Typically an ultrasound and endometrial sampling via an endometrial biopsy in the office. And then if both of those are normal, it would be dependent on the rest of her history as to what the process would be.
Would you recommend FDNC?
Potentially, if there's polyps, that might be a recommendation to go in and actually most gynecologists are doing a hysteroscopy along with that. So they actually put a little telescope through the cervix and look at the lining of the uterus and actually visualize it and then remove any tissue or polyps that are in there. Yep.
and is that an office procedure, an outpatient surgery? What's the setting?
It's typically outpatient. Some physicians do them in the office. Some physicians do them in an outpatient surgery center. Most of them are done under some kind of anesthetic, whether it's local sedation or more of a general. It just depends on each surgeon's preference.
Do you see those coming back? Oh, do you see the polyps coming back?
My experience has been that the majority of the polyps are benign or non-cancerous, but there is always the concern of a cancer, and that's why we take them out and have them evaluated by the pathologist to look at that tissue.
I just had a question by a woman that is close to me. She says that when she was 40 years old, doctors, she says, were reluctant to admit that the premenopause symptoms in particular could be so severe. She said, they were as severe as any menopause symptoms at age 40, and she had them for 25 years. So has the thinking changed since, a few years ago on that?
Well, the average age of menopause is 51, but anything 40 and above is considered normal. 40 to 45 for menopause is considered early. The majority of women are in menopause between 45 and 55, and after 55 is considered late. So it's not out of the question that she might have symptoms at 40 and even be in menopause at 40, and those symptoms can be significant. The average duration of the vasomotor symptoms or the hot flashes for Caucasian women is 7 years. It tends to be longer for Hispanic and African American women and shorter for Asian women. So that's the average. So some women may have hot flashes for 10, 15, 20 years or more.
And she had a question after 65 years of age. Is a woman supposed to have pap smear and cancer screening for ovarian cancer tests? How often should these exams be done?
So there really is no good cancer screening for ovarian cancer. that's more symptom driven. Unless someone is a genetic risk for it, then there are some surveillance that can be done. As far as the pap smear screening goes, pap smear screen for cervical cancer, and the current recommendations are to start those at age 21 and do them every 3 years until the woman is 30. And then at 30, we add HPV screening to that pap smear. And if both are normal, do them every 5 years. Then if a woman has had consistent screening with normal results at age 65, if she's not at high risk, she can discontinue pap smear screening.
I have a question because I'm in between hormone pills. I had breast cancer and some lymph nodes removed. But my body's been reacting to them. So the last one is the one you just mentioned. How do you say it? Tamoxifen. Yeah. And so we're going to have a meeting hopefully this month about this because I've had polyps removed. I had about 3 removed.
Mm-hmm.
And as a diabetic, there's possible side effects of blood clots. Is that a concern I should have? Because that was what I addressed with my oncologist on that one.
A concern staying on the tamoxifen,
Or to get on that, because she says, well, we'll have to have a discussion because that was like the last medicine to try now for me, and because I've had physical reactions to the others.
Oh, I see. So she's looking at putting you on tamoxifen instead of a different medication.
And she had me look at possible side effects, and those are the things that concern me.
Well, yeah. So if you've had polyps in the past that weren't associated with tamoxifen use.
No, they was way before, and it was right after.
And just to clarify, the polyps we're talking about here are polyps up inside the uterus?
Yes,
Yes.
that's where I had.
Not colon polyps. Okay.
No,
Right.
it was inside the uterus, and it had to be surgically removed.
Right. So we see those not infrequently in women of childbearing age and perimenopausal women, and occasionally not too much in postmenopausal women unless they're on a medication. And by and far, they're benign. They come from the glandular tissue that's in the endometrium. So that wouldn't be a reason to not be on the tamoxifen. You would still want to have the same surveillance as anyone else that's on the tamoxifen.
So since I've had those polyps, those was years ago, 7 years ago, I'm looking at my husband, that I've had those removed. Should I be having regular cervix examinations? Haven't had since the operation.
Well, the polyps, you don't see, you have to do imaging to see those polyps unless they're so big that they actually drop out of the cervix, which happens occasionally. But most of the time you can't do an exam in the office and see them. It usually requires like ultrasound imaging. And typically we don't do routine ultrasound imaging unless there's concern such as abnormal bleeding or postmenopausal bleeding.
Oh, okay.
And the pap smear is not a test that's designed to look for polyps in the uterus or to look for endometrial cancer. It's a test to look for cervical cancer, which is a different cancer. And you said that should be done and discontinued after age 65 if there's no other risk factors?
Right. If they've had consistent screening and it's been normal and there's no other risk factors.
Yeah, because mine was benign, and so nothing seemed concerned to have follow-up. So I guess I'm good. Thank you.
We've got a question from a viewer. They wanted to know where they could find a listing of doctors in your specialty area, where they can find a listing of providers.
Oh, well, if they're interested in menopausal medicine, then the North American Menopause Society has a list of certified menopausal practitioners, and those are doctors that have done the testing and become certified. They also have a list of doctors that are members that have interest in the area that aren't necessarily certified, but are certainly capable of taking care of their needs. And the website for that is menopause.org.
Great. Besides gynecologists, OBGYN that get the additional training, I would imagine some endocrinologists might be certified in menopause management or not?
Not too many endocrinologists
Okay.
because they deal with hormones outside of the ovaries for the
Okay,
most
for the
part.
most part, yeah.
Internal medicine,
Some internal medicine.
family doctors,
Okay.
nurse practitioners, urology. Those tend to be the main ones. Yeah.
Okay.
And OBGYN.
Great. Well, Dr. Kemp, thank you so much for being with us. Dr. Karen Kemp-Glock, OBGYN, menopause and sexual health specialist. And thanks for helping to enlighten us. And, part of the process of even having this podcast is to normalize some of these conversations
Right.
that can be awkward. And I encourage all patients to feel in control of conversations with physicians. And if you have issues related to menopause or sexual health, please bring them up. If you're talking to a physician who isn't comfortable or doesn't have the expertise, then that's an appropriate time to seek a specialist who does have that expertise. So thank you so much.
You're very welcome. Thank you for having me.
And thanks everyone for watching. If you know someone that would be interested in seeing this program, it will be available to you on demand at the Above and Beyond Cancer YouTube channel and the MercyOne Cancer Center website. Please join us again next week. Thanks, everyone.